Hi, colleagues. It's my pleasure to be here on this 2021 World Delirium Awareness Day to speak about the results of the program of work in my lab focused on family engagement in the prevention, detection, and management of delirium in the critically ill. My name is Kirsten Fiest, and I'm an assistant professor in the Department of Critical Care Medicine at the University of Calgary. I have no conflicts of interest or disclosures to declare. I don't need to tell this group what delirium is and its signs and symptoms, but what I will get you to focus on a little bit is just how the prevalence in the context of the studies I'm going to be discussing today differs from that globally. So a systematic review and meta-analysis published in the BMJ found a pooled prevalence of delirium around the world of 31.8%. In Alberta, where the research is that we're conducting, the annual prevalence of delirium based on the ICD-SC scored twice daily in all critically ill patients across the province is 56.7%. Our group did a systematic review and meta-analysis of the subtype-specific prevalence of delirium, which was published in Critical Care Medicine. And we found overall, the most common subtype of delirium was hypoactive at 47%, followed by mixed delirium at 29% and hyperactive delirium at 4%. There are, of course, risk factors for delirium that are commonly known, some of which are specific to the ICU. In terms of individual patient factors, age, comorbidity, and severity of illness are risk factors for delirium. There are also ICU-specific risk factors, such as the use of benzodiazepines, surgery, and mechanical ventilation that can lead to delirium in the ICU. And then finally, environmental factors, such as sleep-wake disturbances, can also increase the risk of delirium. In terms of the management of delirium, there are no strong evidence from guidelines to support the use of pharmacological interventions for delirium. There are, however, a number of non-pharmacological interventions that are recommended, including maintaining sleep-wake cycles, early mobility, orientation, and familiarity. It should be noted that if individuals are using pharmacological interventions, the guidelines do recommend using dexmedetomidine rather than a benzodiazepine. Post-intensive care syndrome is a cluster of symptoms that develop in individuals who survive an ICU stay, and they can broadly be categorized as cognitive, psychiatric, and physical. But they are really quite common in people who live through their ICU stay and can have profound morbidity throughout their life following the ICU, and these can all actually lead to increased mortality post-ICU as well. Not only are patients affected by the stay in the ICU, but family members are as well. And a syndrome known as post-intensive care syndrome family can also be seen in family members of ICU survivors. The most common symptoms of post-intensive care syndrome family are depression, anxiety, and post-traumatic stress disorder. From previous research in critical care and elsewhere, we know that family is frequently at the bedside, that they want to be engaged, and that they may actually notice subtle changes in a patient first. And therefore, family engagement may actually improve patient and family outcomes. And this is the really central tenets of why we are embarking on this family partnered program of work. Some myths and misconceptions, however, regarding family presence include that it might interfere with care, that it exhausts patients, that it is a burden to families, or that it may spread infection. What the research tells us is that family presence may actually decrease patient falls, decrease cardiovascular complications, and we see no increase in infection rates when family is present in the ICU. You'll all be familiar with the ICU Liberation Bundle, which is a series of different interventions that can be employed in ICUs to help liberate people from the ICU sooner and to mitigate any complications following an ICU stay. We chose to combine components of the D part of the bundle, delirium, assess, prevent, and manage, with the F part of the bundle, family engagement and empowerment, to create an intervention to support patients and families in the ICU. This is an overview of our research program, which began in 2016 and goes to present. Those papers highlighted in red will be the focus of the talk today. Just to give you a bit of background, very quickly, the work that we did prior to what I'll speak about today is a systematic review looking at validated caregiver-centered delirium detection tools. We searched literature and found 3 tools that are caregiver administered that could be feasible in the ICU. The FAMCAM, the SOUR7, and the iAged. And we decided to compare both the FAMCAM and SOUR7 in our future study. We then embarked on the Family ICU Delirium Detection Study, the pilot study, to determine the feasibility and acceptability of family-partnered delirium detection in the ICU. This pilot study determined that both the FamCam and SOUR7 were feasible and acceptable tools for use in the ICU. We also had to do some background work for an educational intervention related to family involvement in delirium detection. We developed some ICU delirium education materials in collaboration with a multidisciplinary care team, including social workers, occupational therapists, nurses, and physical therapists. We ultimately developed a 6-minute YouTube video. We also developed, validated, and refined educational materials, including case vignettes of hypothetical delirium cases. And we also developed a new tool to measure caregiver delirium knowledge, which I'll speak to shortly. We then conducted a pilot study to assess the feasibility and acceptability of this delirium education intervention. As I mentioned, we had to create a tool to measure caregiver delirium knowledge in the ICU. And so what we did was we adapted the Caregiver Delirium Knowledge Questionnaire that was developed by Dr. Margaret Bull at Marquette University into a 21-item Caregiver ICU Delirium Knowledge Questionnaire. We administered this questionnaire to 158 family caregivers and found it to be a valid and reliable tool to measure caregiver ICU knowledge. So now we move on to the objective of our study, which was to assess whether providing this education to family caregivers improved knowledge of delirium. So we developed the questionnaire and the educational intervention, but now we needed to see if it actually had an effect on delirium knowledge. So in terms of the model of consent for this study, family caregivers were consented and they completed the new Caregiver ICU Delirium Knowledge Questionnaire and the Generalized Anxiety 7 questionnaire pre-intervention. They then completed the intervention, which involved watching the 6-minute YouTube video and detecting delirium in 2 hypothetical case vignettes. We then measured their delirium knowledge immediately post-intervention and at 2 weeks following. 839 patients were screened between January 2019 and October 2019, of which ultimately 99 consented out of 168 eligible patients. In terms of delirium knowledge, pre-test, the knowledge of family caregivers was 13.8 on the CIDKQ with a top score of 21. Post-test, the delirium knowledge significantly increased, and 2 weeks later, that knowledge was maintained. So we found that caregiver delirium knowledge significantly improves after the educational intervention that we developed. So now this brought us to the FID study, the Family ICU Delirium Detection Study, the objective of which was to evaluate the validity of employing family-administered tools to detect delirium in critically ill patients. There was a bit of a different consent model for this study, so we had to consent both patients and family members. Both groups completed demographics, and sometimes if the patient was not capable, the family would complete it on their behalf. In patients, the reference standard delirium assessment was conducted daily by a nurse who was trained for research and trained by a neuropsychiatrist on the administration of our reference standard, which was a 5-page assessment of delirium. They also had the ICDSC and CAM ICU completed. The ICDSC is part of standard of care in all Alberta ICUs and is conducted twice daily, once per nursing shift. We also had the CAM ICU conducted twice daily by trained clinical research assistants. Family members completed both the FamCam and the SOUR7 daily on their family members to identify delirium from their perspective. Between December 2017 and March 2019, 910 patients were admitted to a single center ICU, of which 196 were eligible and 147 provided consent. So in terms of measures of diagnostic accuracy, the FamCam had a sensitivity of 54%, a specificity of 77%, and an area under the curve of 65%. The ever prevalence of delirium based on the FamCam was 37%. For the SOUR7, the ever prevalence of delirium was the same at 37%. However, the measures of diagnostic accuracy differed. The sensitivity was 73%, specificity 69%, and area under the curve 71%. We also were curious about how the clinical assessments performed according to the reference standard to see how they compared to the literature. So the ICDSC had an area under the curve of 77%, in the CAM ICU, an area under the curve of 80%. So we wondered, how would the family tools do with detecting delirium if they were combined with the clinical assessments? Because we knew that family tools would never be used alone, and they would always be used in Congress with another tool. We found that the area under the curves were fairly similar when combining the FAMCAM and SOUR7 with both the ICDSC and the CAM ICU, with area under the curves ranging from 75% to 79%. So the ultimate question of this study was, can family members detect delirium in critically ill patients? The answer is yes. However, they are no better than clinical assessments. So the implication of this is that in the absence of formal clinical delirium detection, family members may be able to identify delirium in their loved ones. However, we knew that we needed to get a little bit more information to kind of figure out why the tools didn't perform as well and what we could do to make any future studies better. So we conducted a sub-study of the Family ICU Delirium Detection Study, where we sought the perspectives of patients, family members, nurses, and clinicians on using family-administered delirium detection tools and barriers and facilitators to their eventual use in patient care. We conducted 3 focus groups, one with patients and families, one with nurses, and one with physicians. 7 patients and family members participated, 6 registered nurses, and 5 physicians participated in each focus group. Overall, there were similar themes between the 3 groups. The first were perceptions of the acceptability of family tools, so whether or not people would find them acceptable for use, whether family members would appreciate using them. There were considerations regarding feasibility. So is it possible to have family members participate in this? Is it possible to have them talk about the results of their screening to the care team, for example? And the final theme was strategies to support implementation into care. So what can we do to ensure that if we do use family delirium detection, how can that best inform patient care? And so ultimately, the question was whether or not family participation in delirium was feasible and of value. And we found that it was. However, we also found that the tools didn't perform as well as we expected. And we suspected that that could be because of a lack of education on ICU delirium, which led us to develop the Activate study, which is a family-administered delirium prevention, detection, and management intervention. The objective of the Activate study is to determine whether family caregiver involvement in the prevention, detection, and management of ICU delirium improves patient and family member outcomes. So the design of this study is a multi-center randomized controlled trial. We are planning on conducting this in 4 hospitals in Calgary to start, and then expanding to other ICUs as feasibility warrants. So the way the study works is it's a 1-to-1 allocation of the intervention, where one individual is randomized to usual care. In our center, it's the ICU delirium pamphlet, and usual care also includes the ICU liberation bundle, which has been implemented in Alberta ICUs for 5 years. The ICU Delirium bundle, which our team has created, includes education. So you remember that educational intervention with the video and with the training and with the delirium knowledge. They'll receive that. They'll also receive training on how to detect delirium through the FIDS study. And then they'll also receive information on how families can partner to prevent and manage delirium. Again, this is a dyad consent model where patients and families consent and both groups complete demographics. The ICDSC, as a clinical measure of delirium, is recorded in the electronic medical record and can be obtained through our eCritical database. So we will get a clinical measurement of delirium from that. Family members will complete a series of baseline questionnaires, including demographics, measures of depression, anxiety, post-traumatic stress disorder, distress, and family needs in the ICU. They'll then participate in either the intervention or control group, and then receive receive questionnaires at 1-month and 3-month follow-up. In terms of the prevention and management piece, which I haven't spoken about before, we developed a 3-pronged protocol to support family partnership in the prevention and management of delirium, which was created with our multidisciplinary delirium working group that includes social workers, physical therapists, occupational therapists, nurses, and physicians. So we developed an orientation protocol, which involves providing necessary devices such as hearing aids or glasses to patients, orienting them to the date, and potentially talking to them about the news of the day. The cognitive and mobility protocol includes having a patient participate in mobility activities at their level and as approved by the physical therapy team, and also having them engaged in some cognitive and stimulating activities, such as if they're capable of doing word searches or coloring or playing cards, etc. And then finally, an environmental protocol. So providing earplugs, reducing noise, and maintaining a regular sleep-wake cycle if possible. These are all activities that family members can participate in to prevent and manage delirium in the ICU. So our primary outcome for this trial are family member symptoms of depression and anxiety. And our secondary outcomes include the prevalence, duration, and severity of patient delirium, and then the burden of delirium on family members. So in terms of what's next, we're going to continue activate recruitment. So we've been paused twice due to the COVID-19 pandemic and are hopeful that we can start recruiting patients again into our study at the beginning of March. We hope to expand this trial to sites outside of Calgary, and we're actually conducting a version of the FID study, the Family ICU Delirium Detection Study, in pediatric populations at the Alberta Children's Hospital in Calgary and at Hamilton Health Sciences Centre in Hamilton, Ontario. I'd like to thank a large and diverse group of individuals who participated in many aspects of the study, including a number of patient partners who were instrumental to the conception, to the design, to the execution and dissemination of these results, and to many research partners, some of whose names may be familiar to you on the screen, who were instrumental in mentoring me and supporting my team through this. Thank you.